Hey everyone, and welcome. Let's talk about that moment. You know the one. You're in a consultation, you're talking about weight, and you just hit a wall. It's frustrating, right? Well, you're in exactly the right place. Today, we're going to totally reframe those tough conversations. We're going to go beyond just the numbers on the scale and dive into the art and science of motivational interviewing. The goal here is to help you have conversations that are not just effective, but also empathetic and lead to real, sustainable change.
So here's how we're going to do it. First, we'll tackle why our usual way of helping sometimes backfire. Then we'll introduce a whole new philosophy called PACE and a 4-step map to guide your chats. After that, we get really practical. We're going to build your toolkit with something called OARs, show you how to turn resistance into motivation, and then we'll wrap it all up with one simple, powerful step you can literally use tomorrow. All right, let's kick things off with a scenario that I know every single one of us has experienced. We see the lab results, right? The high blood pressure, the climbing A1C, and every instinct we have, everything our training taught us just screams, fix this. So we lean in, we give our best advice, and poof, an invisible wall just goes up. It feels like the more we push, the harder they push back. And this quote just nails the problem. We create this weird conversational tug-of-war. By taking up all the space, arguing for change, we basically force our patients to argue for staying the same. They're ambivalent, and we've taken all the good arguments. So what's left for them? They're left to defend the status quo, to voice all that sustained talk. We literally become the engine for their own resistance.
You know, there's actually a name for this. It's called the writing reflex. It's that automatic, totally well-meaning desire to jump in and make things right. But here's the thing. It's a trap. It puts us in the role of a director, just handing down orders, instead of a guide who's on the journey with them. Learning to spot this reflex in yourself and consciously quiet it down, that is the absolute foundational skill of motivational interviewing.
So if we stop ourselves from jumping in with the writing reflex, what do we do instead? What do we step into? Well, we adopt what's called the spirit of motivational interviewing, and it's perfectly summed up by the acronym PACE. And I want to be clear, this isn't a checklist of techniques. It's a real, fundamental shift in our mindset that changes the entire vibe of the conversation.
Let's break PACE down. P is for partnership. This means the patient is the expert on their own life. We're in this together. A is for acceptance, which is about respecting their autonomy, their right to choose, even if we disagree. C is for compassion, genuinely wanting what's best for them, focusing on their quality of life, not just a number on a chart. And finally, E is for evocation. This is the big one. It's the belief that the motivation, the reasons for change, are already inside the patient. Our job isn't to install motivation, it's to help them find it and draw it out.
Okay, so with the PACE spirit as our compass, we now need a map. Because MI isn't just a meandering, aimless chat. It actually follows a very clear 4-part structure that takes you logically from that first handshake all the way to a solid plan.
And these 4 processes, they build on each other like steps on a ladder. You got to start at the bottom. First is engaging. That's the foundation. It's all about building trust and rapport. Next is focusing, where you work together to decide what you're actually going to talk about. Then you get to the real heart of MI, which is evoking. This is where you pull out the patient's own why. And only then, once they start talking about wanting to change, do you move to planning. You can't skip ahead. Each step is crucial for the one that follows.
So this brings up a really important question, and one that trips up a lot of clinicians. You know, we're so driven by outcomes. We feel like every single appointment has to end with a concrete plan. But is that really true for good MI?
And the answer is a huge, liberating yes. Absolutely. A successful MI session might end with no plan at all. Think about it. Sometimes our main goal is just to help a person explore their own mixed feelings. Helping someone move from no way, I'm never doing that, to maybe I could think about it. That is a massive clinical win. It's about respecting that maybe they're just dipping a toe in the water, and that's okay.
All right, so we've got our philosophy, our PACE spirit, we've got our 4-step map. Now, what are the actual tools we use to paddle our way through those conversations? These are the real hands-on micro skills that make motivational interviewing come alive.
The toolkit is super easy to remember with the acronym OARs, just like the oars you'd use to steer a boat. These are our 4 core skills: open-ended questions, affirmations, reflections, and summaries. Getting comfortable with these 4 skills is really the key to putting all this theory into practice.
And this slide shows you exactly what they look like in the real world. Instead of asking a yes/no question like, do you track your meals? You ask an open question. What's that been like for you? It invites a story. An affirmation isn't just saying good job. It's spotting their inner strength. Like, wow, you made it here today, even after that tough week. That shows real resilience. A summary is like a little bouquet of all their change talk that you hand back to them. But honestly, the real superpower here is the reflection. You're not just parroting them, you're guessing at the meaning behind their words. It's like holding up a mirror so they can hear what they're really saying.
Now here's the secret. We don't just use these OAR skills randomly. We use them with a very specific mission: to listen for and deliberately grow a certain kind of talk from our patients. We're listening for the language of change.
So in any of these conversations, you're going to hear two competing voices from your patient. There's sustain talk, that's the voice of I can't, I won't, the yes buts. And then there's change talk, that's the voice of I want to, I could, I need to. Our job isn't to fight with the sustain talk. Our job is to be a detective for change talk. When we hear it, we use our oars to reflect it, to amplify it, to shine a spotlight on it. Because the simple truth is, people believe what they hear themselves say.
Okay, let's bring this all together. Picture this patient. We all have them. Their labs are headed in the wrong direction, they clearly feel judged, and the second you bring up diet or exercise, you can just feel the defensiveness go up. They're overwhelmed and they're ready for a fight.
So, on the left, that's the classic expert trap. It's our writing reflex just running wild. It's a list of commands, and it almost guarantees you're going to get a yeah, but response. It instantly starts a power struggle. But now look at the MI approach on the right. That is a complex reflection. It's a simple, calm, non-judgmental statement that just holds both sides of their internal conflict. It says, I hear you. It can completely diffuse the tension and invites them to talk more about the part that is worried. It's a total game changer.
Okay, you might be thinking, but I'm still the medical expert here. I have important info to share. And you're right. So how do we do that without falling back into the expert trap? We use a simple recipe called elicit, provide, elicit. First, you elicit. You ask permission. Would it be okay if I shared something about that? Then you provide the information, but you do it neutrally, like an offering. Some people in your situation find that. And then, this is the most important part, you elicit again. What do you make of that? Or how does that land with you? This keeps them in the driver's seat.
We have covered a lot of ground here. The why, the what, and the how. We've gone from understanding that writing reflex to getting our hands on the OAR skills. So the big question is, where on earth do you start in the middle of a crazy clinic day? Well, before we talk about that very first step, I want us to just sit with this for a second. This is the core truth. MI isn't a magic trick we do to someone to make them change. It is a way of being with them as they figure it out. We are their guide, walking right alongside them. It's a true collaboration through and through. And that brings us to your call to action. It is so simple, but I promise you it is not easy. Here it is. In your very next clinic, just one time, when you feel that writing reflex kicking in, when you're about to give a piece of advice, just pause, take a breath, and instead try offering one complex reflection. So instead of you should really walk more, try saying, so on the one hand, life is so busy that finding time to exercise feels impossible, but on the other hand, you're worried you won't be able to keep up with your grandkids. Just try swapping advice for reflection, one time, and see what happens.
And I want to end with this because this is about you too. This isn't just about being better for our patients. It is about being more sustainable for ourselves. When we let go of this idea that we alone are responsible for fixing everything, the burden of change gets shared. And that shift, it doesn't just empower our patients. It protects us from the burnout and the exhaustion that comes from trying to carry all that weight by ourselves.